Continue on, here we go, with joints today. And this is kind of where we left off. And so when we finish this joint, there will be some joint information starting to work on the exam. I'll be very specific to what is there on joints. Some of the stuff you're going to see here today, particularly with the 6 different types of joints, the 6 different classifications, and then some specifics about particularly the shoulder and the knee, I think would predominate what you're looking for, and certainly arthritis, which is a big player. And I do not know that we'll get to arthritis today, but we'll surely have this all completed no later than Friday. So that's really that will end or conclude the material. And if I'm feeling ambitious, and if I'm in a good mood Friday, which depends on what happens Thursday night, then I'll put together a recording for this. Hey, this gives you incentive to root for the Steelers. Not that you should need any in any event. It's a battle for the ages. There's 2 quarterbacks. The second time we've had 2 40-year-old quarterbacks. And a not so young 36-year-old Cam Hayward goes, yeah, we're calling it like the icy hot battle. In football terms, he's no spring chicken either. But let's get started. So double check. We're in there. We're recording. We're joined. Everybody's good. And let's begin officially. So here we are. This is where we left off. And this is where and you might remember me saying, I don't know who gets this stuff. The articular surface shape is absolutely the critical piece. We classify joints based on this shape. Okay, you can tell right away if it's an inherently stable or unstable joint. You all did bones. You saw the glenoid alleged fossa, this relatively flat surface. Okay, and you have a head on the humerus. It's really not very secure. You saw the acetabulum on the hip assembly, and you saw the head of the femur. That's why, effectively, shoulders are easily dislocatable, and hips are very, very difficult to dislocate. In a nutshell. So it's all about the shape. Ligaments don't play a limited role. They're a major role. Their job in life, and ligament is a term that's used elsewhere in anatomy and physiology. These ligaments that are associated with the musculoskeletal system, bone, and joint are particularly significant. We dissected a complete lower extremity and stood it up with just bones and ligaments on it, and stood up without any muscles whatsoever. So the muscle tone, as they cross joints, most important. I disagree fervently. Opposed. Diametrically opposed. In other words, I don't know where they guess it. Is it important in reinforcing the shoulder? Yeah. Does it have anything to do with the knee joint or the arch of the foot? Not by a long shot. And so, I mean, people who are not clinically oriented, or they do not have expertise, write textbooks sometimes. I'm not knocking them, or the people who do the PowerPoints, but understand there's errors everywhere. And I mean, that's what my job is, and your other instructors' jobs are, to clarify where they use these errors if they're using material that's made up. So I understand, I always use this as a guide, and I just make sure that I tell you the straight stuff. And I mean, this is great. Like, I would never endeavor, if you want to look at this and learn all the names of the joints, go ahead. And what they are, what bones they involve, but the ones that are important, we're going to go over. So if you're in a field where this becomes relevant, you'll probably be studying things like this. When you do the muscles unit, maybe did you do the muscles with Dr. Robbins in lab? Did he use origin and insertion as the terminology? Well, was that the terminology he was using? Let me ask you a question. We use the term attachments because, I mean, it's there's nothing wrong. Traditional anatomy was taught when you had a muscle, pectoralis major, for instance. You would say, it takes origin here, it inserts here. What's its action? What is the blood supply? What is the nerve supply? Those are the things you had to remember. We know, mechanically speaking, it's not the way it works. So our biomedical folks, and many of them are in the same category over the years, effectively think if you're in the gym doing a curl, okay, that's origin to insertion. The larger or the fixed or the more proximal piece is the stable part. And so you're just flexing your forearm upon your arm. Okay. But if you're doing a chin up, it's the other way around. Now that becomes a quote unquote stable point, and it's working in reverse. That's why we use the term in sport medicine, particularly attachments. So it drives me a little wild, but I understand that I spent a lot. My background has a lot to do with the mechanical aspect, the biomechanical aspect of things like that, where I took it from. So again, immovable. There's a lot of ways. That's why I disagree, and I don't ask for origin insertions when I do the muscles unit. You don't have me for that. You don't have to worry about it. So I'm more about, when I do the lab, I'm more about, these are the major muscles. You should be able to identify those, and kind of what they do. That's whatever Dr. Robbins did. That's his privilege to do it the way he wants. And then we look at the motions, what planes they occur in. But we'll get a little bit to that. So the motion allowed by synovial joints, it's normally we classify it 4 ways. Those little joints in your wrist and in your foot, the little intervertebral joints that, the superior and inferior articular facets, they're relatively flat surfaces. So they don't really move in one plane or another. They just sort of move a little bit, and the accumulation creates motion. So we call them gliding or sliding. They are defined as non-axial. I am confident I will not ask you any of these terms. So do not shut your ears down just yet. It's okay if you do. It's early in the morning. No, it's not. If it moves in one plane, and surprisingly, there aren't that many joints. A classic joint would be the elbow. That's a classic hinge joint. It's all about the anatomy. And what happens if you're able to do this, if you actually look at the joint that's the pivotal piece in the elbow, which has to do with, if you remember back to the anatomy when you did this, the trochlear surface of the humerus, and basically where that indentation is, the trochlear notch on the ulna, that's what makes it just almost pure flexion and extension. So effectively, that's as close. Interphalangeal joints are like that too. So the tips of your fingers, the way their anatomy is, they're so closely mated to each other, there's literally and figuratively no wiggle room that's there. So those are uniaxial. Biaxial means, so for instance, I can do this is biaxial. I can flex and I can extend, and you'll see the terms coming up shortly, adduct and abduct. We'll get to that in a second. And multiaxial, by definition, are ball and socket joints, of which you have 2, the shoulder and the hip. And basically it means the fancy name is called circumduction. You may have had that terminology before. And basically, you can isolate the joint, and whether you're doing your big toe or your index finger, you can trace a circle. Basically a conical range of motion. There's some variations with it. So gliding, angular, rotation, by that. Gliding, flat to flat, intercarpal, intertarsal, again, superior and inferior articular facets that you're familiar with from your bony anatomy. Done. Business done. A lot of movement from a lot of little joints. It's a good news, bad news type of thing. You get a lot of motion, but there's a real concern, particularly in wrists and ankles, when those bones break. They're small. They're all covered in cartilage. And the difficulty with them is they easily become arthritic. And it really, down the road, it can significantly impact. You remember I showed you the projection of that calcaneal fracture. What you didn't see in there was what it might have done long range to all those joints in the foot and their inability. Because it can be a mess. That has cost careers in sport. So here they're just showing you that's what the typical intercarpal bones that are there. We won't go over all the names unless you want me to. You don't have to know them. I could show off. Scaphoid, triquetral, capitate, hamate, those guys. PC. See, I took the course. It's okay. Angular movement, flexion and extension. Okay, and it doesn't always have to be. We look at it. It should be sagittal plane. I mean, it depends on the position. It depends on the species you're talking about. For us, anatomical position, sagittal plane. That's flexion and extension. And certain areas are designed to be able to do it. Your neck, because of all those neat little joints, you can hyperextend it. Your back, you can hyperextend it. It's designed under circumstances to go past the normal stopping point. Not so the elbow. When you hyperextend your elbow or hyperextend your knee, you're going to do damage. And typically what blocks it is bony blocks. Bone, when bone hits bone, things got to stop or something's going to give. Either it's going to dislocate or you're going to fracture something. And that's why you can see those in sport. And I'm an addict for sports. And it was echoed late yesterday as I'm watching a soccer match, which really didn't mean a whole lot. European qualifying. My wife goes, "Is this over yet?" With that tone. The code is there. Turn it off. Which I did. So they'll show you some neat pictures. Okay, great. Flexion extension. We got the picture here. Thank you. And so again, something like that is designed to go past. It's fine. So you can take those in pure anatomy, this way to look at them. We always say the terms going forward in your careers, AB and adduction. Add and abduction sound the same. So when something sounds the same, you basically emphasize a certain letter. Down the road, not here. You'll probably hear two terms called afferent and efferent. If you look at the spelling, it's afferent and efferent. But again, they sound the same. Afferent is incoming. And the nervous system we'll talk about. That's a sensory signal coming. Efferent, think effector, is basically you're responding to that. It's like a reflex. Boom. The afferent signal triggers the efferent effect, the knee jerk. So we always use those terms. Whenever there can be confusion in a clinical setting, you can avoid mistakes by using an extra letter or emphasizing a certain word. This is important stuff. See, everybody will say, "Boy, that was good when you do that." So up in the nursing and in the floor, and when they mock clinical settings, and you use those terms, they go, "Boy, that's good." I'm giving you a heads up. And so AB and adduction generally are about this. So if I'm in an anatomical position, it's like giving a lab lecture. Okay. So when you abduct in the frontal plane, you move it away from the midline. When you adduct this way, you move it towards it. Legs the same way. Anatomical position. Back. Feet are ocular. Anatomical position with feet are straight ahead. You always see illustrations where they're widely spread. That's stance. Okay. When you abduct your feet, you're walking like that. When you adduct, it's almost like a pigeon. I used to do with Dr. Robbins and do all the labs when I first started. But they were totally different than what he's put so much work into them. So involves circumduction, involves all of these, and describing its cone in space or tracing a circle. Some people think the trouble is it's kind of shifting. If you feel your index finger, it's not really tracing a cone. It's subtle movements. It's a bit of flexion and extension and abduction, adduction. It doesn't have the rotational component that a ball and socket joint does. And they're just showing it to you here. Thanks very much. And then in anatomy, we say, and this is transverse plane motion. The rotational movements are basically to say medial toward the midline, lateral away from it. Clinically on the floor, you'll always hear the terms internal and external rotation. Orthopedic surgeons don't use medial and laterals for anatomy class. When we're making a decision on whether to do a hip replacement, we're talking about limitations of internal or external rotation. So be aware of the terminology differs from a classroom to a clinical floor. So heads up on all those. And so you can see these types of, and we'll get into where the rotation is and all that stuff in a minute. Supination and pronation, that's radius and ulna. And again, if you hold your elbow at 90, roll it down, face down, you're pronating something. Supinating your face up. If you have a patient and you say they're in a supine position, they're lying flat on their back on an operating table, where will operations start? If they're pronated in a prone position, they're on their tummy. In surgery, we start on their back because we can get an airway and put an endotracheal tube down, and then you can flip them. when they're asleep. Or put them on their side. You always have to start that way. Why you do that is you have to maintain that airway, and it's very difficult to do when they're on their side. So if you're looking at a career in anesthesia, that's where that becomes relevant. Everybody getting the idea of how the relevance of all of these things are? I can be useful. So, and now it's a little bit different. In the foot, when you sort of make your foot flatter, it's technically pronating. If you kind of stand up on the outside of your foot, raise your arches, that's supination. But it's not something you're probably going to be exposed to. What you might hear about if you have a foot problem, and my feet are flat, we call it a pronated foot. Just to give you an idea. And in the old days, we used to talk with a foot flexion and extension. So if you were stepping on the gas, you'd be extending it. And if you were bring your toes up towards your nose, you were flexing it. Now we call it plantar flexion and dorsiflexion, just to clarify it. And that's pretty much universal. And again, you see that more in sport. Anywhere else. And I showed you, like with an ankle sprain, inversion and eversion. So when you invert something, it's up on its side, so the sole of the foot faces toward the midline. And eversion is the other way. Most sprains are inversion sprains. Eversion sprains generally end up in fractures. And the jaw protraction and retraction. Thanks very much. Elevation, depression, opposition to thumb. Blah, blah, blah. Same to you, buddy. Here are the 6 types. Here's how. Think of this as a potential matching. I'll have 5 of those 6 names, and I'll have the joint labeled with a number. So let's say, ignore ball and socket. If we did A, B, C, D, and E, and then I have a joint, and you have to figure out which joint it is. Got it? I imagine you would see something like that. Very good like that? See, I'm giving it to you. You just have to anticipate. So here, the example, intertarsal or intercarpal joints would be the example. Hinge, got to be the elbow. Or what you're going to see is an interphalangeal joint. Pivot, there's only 2. C1 and C2, and the head of the radius in the radial notch. That's it. The proximal radial ulnar joint. That's it. There's only 2. Condylar, the knee is condylar. Metacarpal and metatarsal phalangeal joints are condylar. Saddle, there's 1. It's the one that allows you to pose your thumb. That's the first metacarpal base trapezium articulation. That's what allows you to do this. So I had my first. We had junior high. They didn't have middle school. Because they taught health. And he came in one day and said, you know what makes you different than the gorilla? You can oppose your thumb. The gorilla's a lot stronger than I. By the way, you were plugged in researching. I found out your question about the gorilla with his muscles. Are you ready to answer the gorilla question? Okay. They're herbivores. They eat a ton of stuff. What happens, they gobble up all that herbivorous stuff. They have an immense amount of bacteria that effectively ferment that, and eventually for energy that becomes fatty acids. All those bacteria die, and they use them as a protein source to make muscle. So if anybody wondered why a gorilla, which doesn't eat any meat, is not carnivorous or omnivorous, and it's just a herbivore, so ridiculously strong. Obviously, genetics play a role as well. But that's the metabolic reason. Moving on. I had to say that because of the gorilla, because that reminded me of that gym teacher. Did I tell you about what the gym, in our day and age, did I do this one with the gym teacher versus the janitor? See, in our school, the difference between the janitor and the gym teacher is very straightforward. They both wore khaki pants. They both wore like a pullover shirt. They all had the thing of the keys, like that. The difference, the guy with the whistle. That was the gym teacher. That was the whole difference. I wasn't sure. Are you the janitor or the gym teacher? And they'd always go to me, Stein, listen up. I'm going, what are you doing? You said, listen up. If you said, listen down, I would have done that. And they tell you to take a lap. Where should I take the lap to? Don't you take another lap. Oh, thank you. And I didn't get you anything. It's okay. It's a gym teacher. All our gym teachers were like guys who got out of the military with a teaching degree and were all, physical fitness freaks. Moving on. So non-axial motions, tarsal, the hinge. They're always going to give you, remember, this is the trochlea, this is the capitulum, remember your anatomy, and it's a saddle, and this is like the reverse saddle. So here's a saddle shape. Trochlea is like a pulley. So it's not quite exactly a saddle as you're going to see with a true saddle shape joint. So I shouldn't have used that terminology. But here, that little notch in this little groove basically limits the side-to-side motion or the rotational component. That's there. Here, pivoting joint. Radial notch, radial head. The other one is C1 and C2. The fact that you can do this. Remember what that is? The axis and the atlas, and the axis, because you rotate on your axis, has that tooth-like projection called the dens, or the odontoid process, right? You learned about that? Moving on. The condylar, there are many. The knee is one because of the menisci. And effectively, it is a distinctly convex and concave surface that allows both two different kinds of motion. In the knee, flexion and extension, and a certain degree of internal rotation. And the same is true when you get it into other areas like the metacarpal phalangeal joints. It's flexion and extension, and they can adduct and abduct when you're in the anatomical position. That's how it works in classic anatomy. So again, this is more lab. That's why I think it should be covered in lab, but I understand the parameters. This is the saddle shape, and this is the reverse saddle. So I apologize for using that. And again, so the unique aspect of this particular bone, the trapezium, and why it is a royal pain in the neck if somebody fractures one of those, because it's going to compromise thumb motion, and it's so vital to everything we do. Okay, and so you really, it's almost though the thumb fractures, and that's what we call a first ray fracture, because the ray is sort of the metacarpal, the phalanges, and even into where it attaches to the carpal area. And there's only one of these, and again, that's what allows flexion and extension, and adduction and abduction, dramatically so, but not complete, no rotational component per se. And there's only two multi-axial joints: the hip and the shoulder. Period. Voila. We got all that taken care of. Down, move it over. Now we get into the specifics of the joints, and then subsequently we'll get into the arthritis nuggets, and that concludes the chapter, and that will conclude what's on the next exam. So effectively, it will be 2 weeks from today. 20. One way or the other. I will probably have, I'm guessing, no more than 60 questions. We'll all do the same mechanics that we had before. We'll figure it all out at that point. Okay, so synovial joints, very diverse. I'll buy that. They're going to look at the main players. By far and away, the one that we'll spend the most time on is right there, the knee. Single most complicated joint in the body. The only other joint that is that complex is the base of your big toe. The hallux, which is the name for the big toe, and the head of the first metatarsal, because it's like the knee. It's got little sesamoid bones in it that stabilize it. It's imperative for being able to walk and put it on the floor. And there's all sorts of stuff that goes wrong in here. It's a real oddball joint. And having operated on a ton of those, I can tell you it's not easy. Jaw joint, modified hinge. Okay, basically, it's a kind of flexion and extension. The mandibular condyle articulates with the temporal bone, hence the name temporomandibular joint. That's an abbreviation that is overused. In the foot, the joint between all 5 metatarsal bases and the rest of the tarsal area, which involves the navicular cuneiforms and the cuboid, is also a TMJ, the tarsal-metatarsal joint. We give it another name that you may have heard of in sport. It's called Lisfrank's joint. And that's and when athletes get fractures there, that basically their career is going bye-bye. That's what happened to the guy from Carolina who can't go away because he wears the most ridiculous clothes, Cam Newton. Great player, MVP for 1 season. But Lisfrank's joint fractures, that's a fracture that you just kind of go, oh, we're in trouble. So this is a modified hinge joint. Okay, that's there. Mandibular fossa. The big player here is a ligament on the outside called the lateral ligament. That's what keeps it where it's supposed to be. So effectively, the movements are sagittal plane. They effectively are depression and elevation. The one that is active is to elevate it, closing the mouth. Opening the mouth is gravity. And you inevitably, in any species that we encounter, in any animal species, that is a consistent finding. Think of when they have to subdue an alligator and try to get it back into the Everglades or wherever it's going. The most important thing is keep that. It's tough for them to open their mouth, but if they get it closed, you're not open. You do not want to be the person who gets anything stuck in there. It's very, just go look at any video about that, read anything, and that's true for a ton of species that are there. Their ability to open their mouth is very limited. The ability to close it is intense. So effectively, the hinge portion, except they call it depression and elevation, and then this has to do with the side-to-side motion. You might remember the muscles involved with that are the pterygoids. So the most easily dislocated joint in the body. Why is it such a pain in the neck? Not because of that, not because of the lateral ligament, and there's really two portions of it. Here you have the capsule, you have this ligament overlying this ramus of the mandible on either side, the rami, as it were. Is that bad boy? There's an articular disc in there. And what happens, even though it gives it the ability to shift, move forward and backward and do side to side, that adds something that can go wrong. Anytime you add additional structures in a joint or anywhere, it's more stuff to go wrong. And if it's damaged, that's when people will begin to suffer. And typically the damage is progressive. Most will tell you, if you're in a dental field, it has to do with bite. And most people know somebody who has this problem, and a lot of times they have to have some device when they sleep. A lot of times that's a contributing factor to sleep apnea, sleep disorders. There's all sorts of, it's been pretty well studied, these kinds of things. So that plays a really pivotal role involved in that. Just to give you the clinical nugget that's associated with it, it's the most common because of the shallow socket of the joint. I don't know if that's why. Almost always dislocates anteriorly, and it's not so easy to push back. Because people when that happens to people, they panic, and you got somehow. Typically, you need some type of sedation. So, I mean, in the old days when we had things like that, we'd inject Valium, and that would sedate them pretty good, and you could pop things back in like shoulders and joints. I don't know what they do today. So all the symptoms you can become familiar with, all the different sounds that are associated, joint stiffness, etc. Grinding teeth, but also can be due to jaw trauma or poor occlusion. So bite plates are useful, etc. This joint is effectively, this is the difference, anatomically speaking. The shoulder, the upper extremity, and the shoulder in particular are designed to have a great deal of mobility. The lower extremity and the hip in particular are designed to have a great deal of stability. It's a trade-off. There's no other way to look at it that way. The architectural design is for that. I told you before, there's another articular disc in the sternoclavicular joint. That's the sole attachment of the upper extremity to the axial skeleton. The hip has a much more significant, that's that sacroiliac articulation. Remember those auricular surfaces that are on the sacrum and on the ilium? Ringing a bell? I know you had them in anatomy, right? That's a sacroiliac joint. That is a lot of surface area, very little here. Articular disc here, none here. Those things so it's a rather substantial, and then on top of that, you have the pubic symphysis, which assists it. So understand that there's a lot that goes on with regard to these things that are there. So stability is sacrificed for free movement. It's a ball and socket joint, and if this is a wonderful analogy, like a golf ball on a tee. So, I mean, there's even with, and you will see what we have anatomically in there is a term you probably have heard of. It's a big lip made out of fibrocartilage. It's called a labrum. Labrum means lip. You have one in the acetabulum when we get to the hip, and you have one here. And so you'll hear about, oh, so-and-so has a torn labrum in sport. And it can be either in the hip or the shoulder. The shoulder is much more common. Okay. For these, and even then, there's again, you hardly have any of that quote unquote wall in that quote unquote socket. At best, it resembles it. The articular capsule is also not strong, where the hip is very strong. This is the consistent difference between the two structures. Mobility, the stability. And so you saw that illustration before. What keeps it in place? Did you talk about the rotator cuff in lab? You mentioned it en passant, in passing. Did you ever hear the term en passant? So in passing, like laissez-faire, you heard that term? Did they have history in high school? I'm sorry. I'm sorry. Not much. I got you. There's no saying about if you don't learn from history, you're doomed to repeat it. Nevertheless, okay. I'm trying to find a right way to frame this. Okay. There's very little in that, and I'd have to go get the skeleton. But you can go back in the lab and take a look at any of those articulated skeletons. The door's open right now. It's in there, because I was in there before. There's very little holding it in. The rotator cuff involves 4 muscles. And really, and one of them is really not terribly significant. In anatomy, you learn those surfaces. It's the subscapular fossa, and the spine of the scapula had the infraspinous and the supraspinous fossa. Muscles in all of those. So anteriorly, you have subscapularis, and the tendon is the only one in the anterior aspect that inserts into the head of the humerus. Posteriorly, you have 3: supraspinatus, infraspinatus, and something called teres minor. So there's a lot more stability from the back. The capsule's not very strong. The bony overhang is superior and the scapula posterior. So if you go back and look at those, inevitably when this dislocates, it dislocates anteriorly and inferiorly. And we see them all the time. It's a very, very frequent dislocation. In sport, we see a lot of them happen in fights. We see a lot of them happen in boxing. So there's nothing unusual about them, but based on the anatomy. And so really what's securing that in the joint is the rotator cuff. And my students in the lab would have to know all the 4 muscles and which ones were posterior and which ones were anterior. It's aided by a lot of other structures. There's a lot of other muscular structures that may not insert here, like the pectoralis major inserts here, for instance. Latissimus dorsi back here. So they're helping. The long head of the biceps is a super stabilizer in the sense it goes all the way over and is in the joint. Again, now you have a tendon with a bursal sac in the joint, a layer of complexity. You have a lot of bursal sacs that are there. More complexity. That's the subacromial bursa. That's there because that's the acromion process. Very commonly inflamed when we talk about bursitis. And then down here, okay, you have other structures. So you remember the coracoid process, the short head of the biceps goes into that. So all of these structures, it's all about tendons. It's all about the different muscular and soft tissue structures. It's very little about the bone when you're talking about the shoulder. And they'll show you these things that you can begin to see. So there's not a lot to it. I mean, that's not much of a socket where I come from. If your mom said, show me a socket, that's not what you would show. So the labrum, and it's named for the anatomical structure of the glenoid, fibrocartilaginous rim around the cavity, adds depth. So it's still barely a third of the head of the humerus. Not a lot. So, and a lot of ligaments that are there. You don't have to know the names. I don't care. Look at all the bursal sacs that are there. So there's a lot of structures that here's the subacromial one, here's the subscapular one. You don't have to know any of those anatomically. That's lab. Okay. The extraordinary tendon sheath. You can see all of that. Now you're taking a good look. Here's the capsule. And if anything, capsule is stronger posteriorly. Here's the acromion and the coracoid process. They're a bony overhang. The clavicle's over there because the big joint, your AC joint, when you hear about shoulder separation, is the acromioclavicular joint. And I can't tell you how common. These are extraordinarily common. The most fractured bone in your body is? Nope. Nope. And not your baby toe. Not the old clavicle. You fall down instinctively, you put your arm down. The moment of force goes through, so you end up either separating a shoulder or a clavicular fracture. I mean, Aaron Rodgers, that's what he's had. Those are the things that limited him. Anytime he was out, it had to do with the clavicle fracture or related to the clavicle. So a separation is the acromioclavicular joint shifting out of position, where a dislocation, okay, is where effectively it's popped out. So that's a joint that separates rather than dislocates. It's very rare. That's only a grade 3 shoulder separation. So there's a whole lot of this stuff. And when you go into, I have a fairly extensive background in traumatology. And so when you work in an emergency room, you see all this crap. So, I mean, it's not really joined to scale. Here's the glenoid cavity itself. The labrum is just a rim. You can see in that sort of reddish color. And then you have the capsule that are there. Super stabilizer, travels through it. The four muscles of the rotator's cuff. This is a minor muscle. It doesn't do a whole lot. Why is it included? Because anatomically, its insertion or its attachment on the femur, on the humerus, is in the head. So again, it's an anatomical distinction rather than functional. That's what cartilage looks like, everybody. And this is someone who did not have any arthritis. It's beautiful. It's white. It glistens. There's no pock marks. There are arthritic joints, totally different. Irregular colors, it's soft in some areas, rock hard in other areas. It's almost like it's like a road that's full with little tiny potholes and things like that. Pick a road around here. So it gives you an idea of what it looks like. So injuries due to mobility in the shoulder, weakest anteriorly and inferiorly, this is the way it goes. Poor support from the glenoid, particularly when rotated and laterally abducted. So we clearly see this, the dislocations with that. In the neighborhood in Philly that we were at, we saw a whole lot of fights. Plus we had the city prison service. So we had a whole, watch out if the prisoners had a softball game. We saw some really interesting trauma. We had an inpatient unit that was a locked unit. We had, it's so unusual to get that, quite a bit. And so, and these kinds of things like that. So it's all different kinds of trauma. So I think you might, and they show you the rotator cuff. That was subscapularis. Okay, that's pectoralis major is helping out. There's the deltoid. There's the biceps brachii. They show it to you from there. So all these assist. It's not like they're just there. They have an effect reinforcing the shoulder. The elbow is inherently very stable. Okay. The humerus articulates with the radius and ulna. The ulna humeral area, that trochlea and trochlear notch on the ulna, big player. Hinge, trochlear notch, etc., flexion, extension. The ligament that surrounds the head of the radius and holds that head so it can pivot in that radial notch is called annular. Annular is a term that you see clinically. It means to encircle. It looks like an infection. It's not. People always think it's where it's called granuloma annulare, because it almost looks like it's circling, but in reality, it's an odd skin condition. The big players, what gives side-to-side support are the collateral ligaments, ulnar and radial. When you hear about Tommy John surgery, the most common injury that occurs in baseball pitchers because of the torque they put It's the ulnar collateral ligament. And what they used to do was they would take ligament tissue from the non-dominant area and basically graft it to reinforce that structure. That usually required, that was a good year to year and a half injury. It's there. You hear about that all the time. Nowadays, it's almost inevitable that a baseball pitcher should throw 100 miles an hour. It's going to have. I had a student tell me, "Well, why don't they just get Skeens, give him the surgery now, and skip it?" You can't anticipate it. They had another number one overall draft point, who's now with the Yankees, Garrett. Name's on the tip of my tongue. That the Pirates had. Eventually went to Houston and then to the Yankees. He had it done when he's 32 or 33 years old. So you can't. What they're doing now is similar to what I talked to you about with the inferior tibiofibular. They have it's almost like a sling that they're creating. It's almost like they're tethering it to keep it more dynamic, rather than just doing a graft. And I have to give you that. I'm sure I could find some images of that. So it sits very nicely in there with the elbow. This is that annular ligament, and there you can see. Here's the holding the radius. There's a radial notch, and you have, and the collateral ligaments are not small. It's not a thin strip. It's a whole layer. It's quite extensive. That's involved there. So you can see them dissected away. Here's the annular ligament. Here's that ulnar collateral ligament. You have different branches. So again, what they would end up doing is probably drill holes and put some type of biomedical, advanced biomedical technology substitute in there. Let me just show you it here as well. In the time we have left, let me do the ball and socket joint, and we save the knee for next time. This is a ball and socket. When Mom said, "Show me a ball in the socket," this is what you're going to show her. Head of the femur, very distinctive on that long neck, sitting there in the acetabulum. That's about 2/3 coverage without the labrum. Okay, and hip dislocations are rare. We see them in major accidents. We see them in very unusual circumstances. So this is schematically, this is what it looks like. You can see the cartilage itself, and here they're giving you this extended labrum. It is sitting in there so tightly that when you remove the head, it astounded me the first time I saw the surgery. They had a transcervical fracture, means through the neck. Very common fracture in the elderly. You're going to put in some kind of prosthesis, some type of artificial, at the very least, stem and head. And we opened it up. The person was on their side, this elderly lady, and the bone was there. And effectively, the orthopedic surgeon, I'm holding the tractors. He goes, "I need a corkscrew." And so he's got a sterile, effectively a large corkscrew that you would, just like the way you would use if you're uncorking a bottle of wine, and basically stuck it in where the fracture was in the center of the head going in. And he pulled it out, and it made a sound that everybody heard with an enormous pop, like the cork of a champagne bottle popped in. That's how firmly it was. And he put all his might in. The guy weighed a good 250. He just yanked it out with some force, and boom, out it came. No joke. It's exactly what happened. Orthopedics are very physical, if you hadn't guessed by that. There's a lot of force that's involved when you have to actually break and reset bones. That's there, again, another beautiful head. That's that. They call it ligamentum teres. Teres means round again. This is where, and it's in that fovea capitis femoris. This is the blood supply of the head. You can see that that's not arthritic bone whatsoever, but it gives you an idea of the overall depth of that structure. It's an extraordinarily deep socket. The ligaments are extremely strong. This is not a stabilizer. Okay, I agree, but this is all about blood supply. The greatest stability comes from the deep ball and socket joint. Contradicting yourself from earlier, whoever wrote this. Idiots. Drives me nuts. So we'll leave you here. We'll spend Friday on the knee, and we'll spend Friday on arthritis, and most likely conclude this chapter thing. Au revoir.